Hepatitis B virus. Topics to be covered are viruses causing hepatitis, morphology, pathogenesis, clinical manifestations, lab diagnosis, and prophylaxis. Viral agents causing hepatitis. Hepatitic viruses from A to G except F. It is the most common cause of hepatitis worldwide. Yellow fever virus, hepatomegaly, and causes hemorrhagic fever. Other viruses, sporadic hepatitis, cytomegalovirus, Epstein-Barr virus, HSV, adeno, rubella, hanta, mumps, and enterovirus. Intro. It is most widespread and most important agent causing hepatic virus. Acute self-limiting hepatitis, subclinical symptomatic hepatitic complications, causes chronic hepatitis, fulminant hepatitis, cirrhosis of liver, liver cancer. It is the only DNA virus among hepatitis viruses. It belongs to family Hepadnaviridae and genus Orthohepadnavirus. Morphology, it has three forms: spherical, most numerous, and small form. It is 22 nanometer in diameter, exclusively made up of HBs antigen. Tubular or filamentous, it is the same diameter and 200 nanometer long. It is also exclusively made up of HBs antigen. Complete form or Dane particles, which is less frequent. It is larger and 42 nanometer in size. It is spherical virons. Outer surface is made up of HBs antigen and inner is 27 nanometer size nucleocapsid. Core antigen is HBC antigen and precore antigen and HBE antigen. It has partially double stranded DNA polymerase. Tubular forms and spherical forms. Pathogenesis of hepatitis, viral hepatitis A and D, fecal oral transmission via contaminated food and water. B, C, and D causes through blood-borne transmission, viral replication, and immune response. A and E, direct cytopathic damage to hepatocytes. And B and C, it is non-cytopathic but liver damage due to immune response. And D requires HB for replication and causes severe liver injury. Innate immunity, NK cell and macrophage recognize infected hepatocytes. Interferon limits viral replication. Adaptive immunity, cytotoxic CD8 plus T cells infected hepatocytes and then apoptosis. B cells neutralizing antibodies are produced. Disease progression and chronicity. Acute hepatitis, it is short-term inflammation. Chronic hepatitis, HBV, HBC may persist, causes fibrosis, then cirrhosis, and then hepatocellular carcinoma. HCV, high mutation rates. HBV integrates into host DNA and causes oncogenesis. Autoimmune hepatitis, AIH pathogenesis, loss of immune tolerance, T cell mediated destruction of hepatocytes. Toxic and drug-induced hepatitis, direct toxicity, acetaminophen overdose, and hypersensitivity reactions, isoniazid-induced hepatitis. Alcoholic and non-alcoholic fatty liver disease pathogenesis. Alcoholic toxic metabolite is acetaldehyde, which induces oxidative stress, steatosis, hepatocyte apoptosis. And non-alcoholic fatty liver disease, insulin resistance, which leads to fat accumulation in hepatocytes and causes lipotoxicity and oxidative stress, which results in chronic inflammation and fibrosis. Clinical manifestations following HBV infection. Incubation period is of 30 to 180 days. And then acute hepatitis, it is again in 90 to 95% causes recovery. Rare 5% chronic hepatitis and less than 5% carrier. Less than 1% it leads to fulminant hepatitis. From chronic hepatitis, it is again divided into inactive hepatitis and active hepatitis. Inactive hepatitis causes cirrhosis. Cirrhosis causes liver failure or carcinoma. Carrier, it is of two types, super carrier and simple carrier. Super is immunotolerant chronic HBV infection. Simple carrier is chronic inactive HBV infection. And then pre-ecteric phase, predominant GI symptoms, nausea and vomiting. Ecteric phase, jaundice. Clinical outcome: development of carrier state or complete recovery. Hepatic complications are fulminant hepatitis, cirrhosis, hepatocellular carcinoma. Extrahepatic complications are prodromal phase, serum sickness like syndromes like arthritis, rash, angioedema, hematuria and proteinuria. Lab diagnosis: HBV antigens and antibodies detection methods are ELISA, ELFA, ICT, chemiluminescence. Viral DNA detected by PCR and quantified by real-time PCR. HBV does not grow in any conventional culture system. Diagnosis of HBV infection occurs by demonstration of viral markers of HBV infection, which are hepatitis B surface antigen, HBs antigen. It is the first antigen to be elevated, indicates onset, and it remains elevated during entire duration of acute hepatitis. Hepatitis B pre-core antigen appears shortly after appearance of HBs antigen in serum, indicates active viral replication. It indicates high infectivity stage. Acute chronic carrier elevated in all these stages, so can't differentiate between these stages. Hepatitis B core antigen, it is a hidden antigen surrounded by HBs antigen code. Non-secretory in nature, can be detected in blood, detected in hepatocytes by immunofluorescence test. Anti-HBC IgM antibody, it is the first antibody to be elevated after appearance of HBs antigen, indicates acute HBV infection. Anti-HBC IgG antibody, it is plus HBs antigen plus liver enzymes, it indicates chronic state. Without liver enzymes, it indicates carrier state. Anti-HBe antibody appears after clearance of the HBe antigen. HBs antibody also appears after the clearance of HBs antigen. It indicates recovery, immunity, and non-infective. Only marker of HBV vaccination. HBV vaccination. Here you can see HBs antigen, HBe antigen, but HBC antigen does not appear because it is a hidden antigen. Prophylaxis: active immunization, hepatitis B vaccine. Vaccine candidate HBs antigen, as gene is inserted into each chromosome, and then DNA recombinant technology. Route of administration: IM over deltoid region. Dosage 10 to 20 microgram per dose. Schedule 3 doses, 0, 1, 6 months. Minimum interval of 4 weeks. Proper documentation. Do not start, just continue the dosages. Marker of protection: seroconversion with an anti-HBs antigen and antibody titer of more than 10 ml, it is protected. Less than 10, it is revaccinated. Non or low responders 5 to 10% do not need further vaccination after 2 series. Booster doses are not required. Passive immunization: hepatitis B immunoglobulin or HBIG, indicates HBIG immediate protection. It is given to surgeons, nurses, lab workers. Sexual contact of acute hepatitis B patients, neonates of B carrier mothers, hepatitis B carrier mothers, post liver transplant patients. Timing to be started immediately. Recommended dose 0.06 ml per kg. Single dose IM. HBIG temporary protection for 3 to 6 months. Combined immunization: HBIG plus vaccine, it is more efficacious. For neonates born to HBV infected mother, single injection 0.5 ml HBIG immediately after birth. Full course of vaccine within 12 hours of birth. General prophylactic measures: screening of blood bags, semen and organ donors, safe sex practices, safe injection practices, safe aseptic surgical practices, health education. Thank you.